everyone. I'll just give you a second to take your seats. Thank you very much. So I'd like to welcome everybody to Access and Equity to Inclusive and Culturally Sensitive Sexual and Reproductive Health Services in Victoria and How to Build them. My name's Carolyn McGarble. I'm the Acting Manager of 1800 My Options, and I would like to give apologies for Diane Hill, our CEO. I'd also like to begin with an acknowledgement of country. It's fitting that today, when we are here to explore and learn about inclusive and culturally sensitive sexual and reproductive health services in Victoria, that we acknowledge Aboriginal and Torres Strait Islander women and their knowledge and traditions. These knowledge and traditions have been developed and strengthened over tens of thousands of years and have built and maintained communities, cultures and families. I'd also like to acknowledge Aboriginal and Torres Strait Islander women's strength and resilience in the face of centuries of discrimination, marginalisation and forced removal and separation from land and culture. Women's Health Victoria's vision for reconciliation is that all Aboriginal and Torres Strait Islander women and their communities can live well, healthy, empowered and equal, with strong connections to culture and to country. Women's Health Victoria is committed to a society that is understanding and has respect for Aboriginal and Torres Strait Islander people, histories, knowledge and cultures. And so I'd like to open this forum by acknowledging the traditional custodians of this land, the people of the Kulin Nation, and extend my sincere respect to elders past, present and emerging. I extend my respect to Aboriginal and Torres Strait Islander people who are here today. I recognise that sovereignty was never ceded and that we are all beneficiaries of stolen land and dispossession, which began over 200 years ago and continues today. So today's forum has been developed out of one that we held in May, titled Access and Equity Towards Optimal Reproductive Health in Victoria. And many of you attended and contributed your expertise and knowledge to our understanding of achievements in the sector, as well as shared priorities going forward. At that forum, it was overwhelmingly identified that diversity and inclusion are key priorities for our sector. These are areas that we need to learn a lot about so that we can improve, hone and develop our practice to ensure that we are truly safe and inclusive. So today we bring you Access and Equity to Inclusive and Culturally Sensitive Sexual and Reproductive Health Services in Victoria and How to Build them. It's a very long title. So we see, at Women's Health Victoria, we see today's forum as just the beginning of our work that we are doing towards ensuring that our entire organisation and our services are inclusive and culturally sensitive, and we look forward to the opportunity of sharing in today's learning journey with you. Today, Women's Health Victoria is very deliberately taking a back seat in the proceedings. We understand that while we are experts in bringing people together, in championing women and in advocating for change, there are others in the space that have made it their missions to ensure that health services are safe, appropriate and sensitive to diverse communities, and as such, we want to hear from these people. So we're going to be hearing from experts in their fields, from Women with Disabilities Victoria, the Multicultural Centre for Women's Health, from Thorne Harbour Health and from VACCHO. I want to extend a sincere thank you to all of these organisations and their staff for your support in making this forum so interesting, challenging, educative and useful. We are also truly honoured to be hearing from a panel of people from communities that are historically underserved by the sexual and reproductive healthcare system. And I would like to thank Harm Reduction Victoria, the Vixen Collective, Thorne Harbour Health, Multicultural Centre for Women's Health, VACCHO, the Zoe Bell Gender Collective and Women with Disabilities Victoria for putting us in touch with the individuals who are so generously sharing their experiences and expertise. My warmest thanks to our panel members. We have structured today in a way that respects and reflects the needs of our sector, as well as the stories and the experiences that we'll be learning from today. We look forward to exploring, learning and reflecting with you the ways that we currently practice, the ways that our practice affects the people that we're working with, and the ways in which we can better ourselves both professionally and personally to ensure that our practice is truly safe and inclusive. So I'd like to formally welcome you all to Access and Equity to inclusive and culturally sensitive sexual and reproductive health services in Victoria. I'd like to make special mention of our Board of Management members in attendance today, Candy Broad and Kate Phillips, as well as the many members of the women's health sector and the wider sexual and reproductive health sector today. Unfortunately, as I mentioned earlier, our CEO, Diane Hill, is unable to attend. She is off meeting Minister Makakos at the moment, and she'll be strongly advocating for sexual and reproductive health, particularly for diverse communities, as well as for another strategy, we hope. As I said, Women's Health Victoria are taking a back seat, and I'm going to hand you over to our MC, Dr. Ruth Souza, who will be leading the proceedings for today. We are thrilled to have Ruth here today, whose expertise in this space will, I am sure, ensure that you have a vibrant and engaging day. Ruth is a highly experienced nurse, academic, speaker and facilitator with expertise in cultural safety, maternity, migration, social inclusion and mental health. With a passion for culture and health, Ruth's theoretical interests include feminist theory, post-colonial theory and critical qualitative research methodologies, exploring health inequities and improving healthcare outcomes for marginalised and underserviced groups. Ruth's work experience spans maternal mental health, research into women's experiences of birth in another country, refugee women's experiences of resettlement, and barriers and enablers to cervical screening in migrant women. Ruth is currently the academic convener of the Data, Systems and Society Research Network and Honorary Senior Research Fellow at the Health and Biomedical Informatics Centre at the University of Melbourne. Thank you, Ruth.
Thank you. Hi everyone. Oh, that's more like it. Thank you, Carolyn, for that beautiful introduction, and you're so measured and elegant. Carolyn was one of my first friends in Melbourne, actually. I moved here from Aotearoa 6 years ago, and I met Carolyn on Facebook via a friend of ours, so we kind of knew each other virtually before we met in real life. I just wonder if I could get you to take a minute to be mindful, and I'm just sort of wondering if maybe what we could do together is take 4 collective, very deep breaths, because I'm sure you've all had a busy time getting here and busy lives doing other stuff. And could we perhaps do a collective 4 deep breaths together and just acknowledge our own vulnerability, our own passion, our own commitments to the work that we're doing, and just honour them just for a minute. So just take 4 in your own time. Ah, that's better. Anyway, what I'm hoping for you, and it's such an honour to be here, and to also, I just really want to acknowledge all the work that you do, and in a sector that I think really doesn't get the kind of recognition and acknowledgement that you deserve, and I know so many of you go above and beyond. So I want to invite you to have a day where you get to be nurtured, supported, encouraged by each other. But also, what I do know as someone who's been a clinician for 30 years, I know I look so young, eh? That's the makeup. What I do know is if we do not look after ourselves, we cannot do good work, you know? And if we cannot bring our whole selves to what we do, it's very hard to support others to be their whole selves in terms of health. So that's my invitation to you, to sort of see this day as nurturing. Maybe what I'll do is say a little bit about the day, even though Carolyn's done a superb job of telling you what's ahead. But I guess in terms of maybe how we might work together today, anyone here from Aotearoa? There's this wonderful word that I love, kaupapa. You know, what's our purpose? How are we going to do things? And I haven't found a good English word that's the equivalent. But I guess what the purpose of today, as I understand it, is about learning, perhaps leaning into any discomfort that we might have, be willing to do some learning, hearing from people who are experts in this field, but also hearing from people with lived experience, so that we can get a better understanding of how we can collectively reshape our organisations so they are more equitable. Anyone here on Twitter? Yay! Please tweet. Do we have a hashtag, anybody?
Access for equity.
Access for equity, excellent. And I guess, so that's what's in scope. What's out of scope today is definitions, the questioning of pronouns, or any of those kind of more long-term, complex kind of discussions. We're also aware that there are people that are missing today, so not everyone is going to be heard from. And we acknowledge that there are people who are underserved by the services we offer. So how we see this is the beginning of a conversation, yeah? I am now going to ask you, before we get into housekeeping, whether you can introduce yourself to someone that you've never met before, because I know lots of you know each other, but maybe just say hello to someone that you don't know and kind of tell them what you're hoping to get from today, and we'll get the video lined up with the housekeeping. Okay, that's a beautiful sound. I'm just, one thing I just need to say is we've got people taking photos. If you don't want your photo to be taken, this is what you're supposed to do. Okay, you ready? Give us a sign, okay? Or let us know. Yeah? We're going to get underway with our first panel. We've got two speakers now from Women with Disabilities Victoria. First we have, you're kind of doing this together, right?
Yeah.
Jen and Zoe. Yeah, beautiful. Jen Hargrave, come on up if you like as I read your bios. Jen Hargrave is Senior Policy Officer at Women with Disabilities Victoria, where she has represented the organisation in international conferences and numerous inquiries, such as Victoria's Royal Commission into Family Violence and the Australian Senate Inquiry Disability Abuse. Jen has just completed international research on disability safeguarding in market-based systems with a DHSS Travel Scholarship, and is a part-time community researcher at the University of Melbourne on a disability abuse data project. Jen is proud to be a woman with a disability and to have had opportunities to promote disability and gender rights through her work. Zoe. Dorrity? Zoe is working on a workforce development project to promote better access to sexual and reproductive health services for women with disabilities with WDV. That's you, isn't it? Yeah. She has previously worked with Family Planning New South Wales and New South Wales Health. She's a Bachelor of Psychology and a graduate in Sexology, and has a great passion for training and education in sexual and reproductive health. Can we give them a warm welcome, please?
I'd also like to acknowledge the traditional owners of the land on which we're meeting. I'd like to acknowledge the Kulin Nation, and like to acknowledge that this land was never ceded, and that we'd like to thank them for having us here today.
So, thanks Zoe, and thanks MC Ruth de Souza. Like you, Women with Disabilities Victoria really likes that approach of learning together and feeling okay about not knowing everything. We don't know everything about disability. We want to learn together with you, and we really respect there's a lot of practitioners in the room too who are at the pointy end of all of this, who will have a lot to learn, and that women with disabilities have a lot to contribute around their own personal experiences and what it feels like to be experiencing the system from the other end. Where we're going to probably annoy you a little bit, but hopefully we'll pull through, is is that we are going to talk a little bit about definitions, and we're not going to say there's only one definition, but it helps us get to where we're going. So we're going to talk a little bit about identifying disability, like what is it, how we can think about tailoring language to work with women with disabilities, what Women with Disabilities Victoria is doing in this space, what other organisations can think about doing, and just point you towards some resources. So around identifying disability, we need to start to think about what it is in theory, what it is in policy, and what it is in practice, and all those things connect and inform each other. If you're thinking about where you want to go for a definition of disability, which is often how I start talking to health services about disability, to think about where would you go to find a definition, people are usually a little bit unsure and think about asking the woman if what a disability is to her, or just simply Googling it. But over on the next slide, you can see this isn't even all the definitions. There's many, many, many. From a data perspective, the team I work with at Melbourne Uni, led by Anne Kavanagh, who's a social epidemiologist, look at how disability is recorded in data, and in one study of population of Australia, you might find 7% of Australians have a disability. In another study, you might find 30% do. So the way you ask the questions really changes it. And to think about how you ask the questions, I guess you want to find out, you want to really know why you're asking. In a theoretical perspective, I mean, you'd all be familiar with the medical model, which looks at the person's impairment and how that's the problem and that's an abnormality and it's something that medicine tries to fix. Then of course there's the social model, which looks at society as holding the problems and creating inaccessibility. So it's not the impairment that creates the disability, it's the society, it's attitudes, it's buildings, it's processes, it's all those sorts of things. There's many service models which have definitions around disability, and they're largely around excluding people. So, for example, Centrelink might say you don't have a disability, you don't meet these criteria. The National Disability Insurance Scheme will do the same thing, which all creates a lot of confusion around on the ground for people in the real world about what a disability is. And then, of course, there's rights-based definitions like the UN Convention on the Rights of Persons with Disabilities, and something that all community services are bound to in Australia and our governments, which is the Disability Discrimination Act. And I'm pleased that hospitals in Victoria are having to develop disability action plans now, and we've been thrilled to work with the Women's Hospital on their disability action plan, which they developed in consultation with a group of community members and WDV. Moving on to identifying disability in policy, traditionally there hasn't been disability in sexual and reproductive health policy, and likewise there hasn't been sexual and reproductive health in disability policy. We still see big gaps, but now we're starting to see brief mentions of it in key state and national disability policies. And I think, it'd be interesting to reflect on the sexual and reproductive health policies and strategies that you refer to and that you develop yourselves, and where disability is placed in those. Is it there at all? And what are the flow-on effects for that in practice? How do we get programs funded? How do we get guidelines for practitioners developed if we don't have these things in policy and strategy? Identifying disability in practice. Well, for women with disabilities ourselves, there's multiple factors that might influence whether or not we want to or can self-identify as being a person with a disability. And some of those I mentioned earlier, like we might have applied for a disability support pension 3 times and been told, no, you don't have one. We might feel really proud. We might be part of Victoria's pride movement around disability and want everyone to know we have a disability. Zoe's going to read the quotes for us.
I felt like disclosing during my pregnancy was going to put me under a child protection spotlight, from Julian.
So women also know that there are real consequences, or there can be really serious consequences to disclosing having a disability too, which is something we can work through with you further down the track at a future forum if that's of interest. For practitioners, again, there's multiple factors. Practitioners might not feel confident in this space, and therefore it's quite tempting to invisibilise disability, or to maybe become quite directive and think, okay, we don't have much time, this person's confused, I just need to tell them what to do. And over to Zoe.
It's funny, we ask women such personal questions, but I don't really have any framework for asking women about disability, like whether they can give informed consent from Rose.
Consequently, also workers might be distracted, so rather than avoiding disability, they might get really obsessed by it. And a lot of women with disabilities who go and receive health services share this type of experience with us.
I went to the GP to ask about the pill, but he started asking me about everything I do as a blind person and about my guide dog. I was not there as an ambassador for Guide Dogs Victoria, from Paula.
So, moving on to how we can tailor language. A lot of people tell us that they feel like health professionals tailor their language and censor it. So they might say, they get the impression that the practitioner's thinking, oh, you wouldn't be sexually active, so there's no way I need to talk to you about your birth control options. I've skipped around the slides a bit, sorry about that. Another way of thinking about tailoring language is to think about strengths-based language, and I'll pop down the back some of these resources, and in the slide pack we've got a link to them too. We developed these with Domestic Violence Resource Centre, and it talks about taking a strengths-based approach. So rather than saying something like how dependent are you on your carer, or how much does your husband do for you, you might say tell us about what your support requirements are. Rather than describing someone as not being able to talk, you might say someone has communication access requirements, those sorts of things. Another thing that we'd love to see everyone build up confidence in is some language around asking people questions around what their access requirements are. So maybe Zoe, you could read those for me.
Is there any way that we can make the service more accessible for you? And what are your communication access requirements?
In response, some options for practitioners are to speak in plain English and remove jargon, provide pictorial information, and at the end of the resource pack we've got some links to South Eastern Centre Against Sexual Assault, who have developed a lot of easy English materials with pictures that help describe what they were trying to communicate in their workspace. Or we can develop language around advocating to our services that we need longer appointment times for certain population groups. For example, if someone's got a communication disability, it might not be realistic to have a 15 or a 30-minute appointment. It might take much more time to be working with an interpreter or working with a communication board pointing at pictures. Over to Zoe.
So, beyond all those excellent suggestions, that we have even more. So one of the really key things that we need to focus on is getting representation data. Like Jen said, it can vary. The generally accepted government figure is around 20% of women in Victoria have a disability. So we really need to count them to know where they are, what needs they have, all those kinds of things. We would really like to see women with disabilities represented in your communications. So, it's not just having someone who looks like they have a physical impairment, but really representing, advocates, people in your local community, making sure that women with disabilities know that your service is for them. Representation in policy and advocacy, so advocating for more accessible programs, advocating to management and boards. So this can be you. You can be an advocate. You can find allies in your organisation. You can find advocates in your community. I guarantee that they're there. Whether you're listening to them, you might need to go and find them, but they're definitely there. Representation at events, so making your events accessible. If there aren't any women with disabilities at your event, maybe ask yourself why. Why are they not there? Is it because we didn't put information on the event around access? Was it because it was held in a room up a flight of stairs? Was it because we didn't partner with local disability organisations to make sure that people knew that it was happening? Things like that. I just covered my next point, make connections with disabled persons organisations and disability service providers. So I guarantee that there's disability service providers in your area that are really thirsty and hungry for knowledge. They really need a lot of support around sexual and reproductive health. For example, we worked with Melbourne and we did some training around gender and disability, and the one thing that they wanted to talk to us about was sexual and reproductive health, because it's such a huge issue for them. They want to talk about consent, they want to have some guidance, and you're the experts in their area, so they want to talk to you. So they're there and they're willing to work with you. Lastly, make a disability action plan. So this is a really comprehensive policy-based approach, which just makes sure that everything is there to back you up when you're making decisions, when you're applying for projects, making sure that your service is inclusive from an organisation-based perspective. And also representing women, employee women with disabilities is obviously a really great way to support them, and also on your board, so that you're having people to guide where your organisation is going to make sure that it's successful. So on that note, I have been developing the Access project. So we're working with Women's Health in the North and also the Royal Women's Hospital in developing training. So we're just about to pilot with Women's Health in the North. We're providing them with some internal training. At the moment, we're focused on places in the north, but if you are interested, please get in contact. We might have spare places at the training that we're running in the community through WIN, so you can either contact me or Rosie, and that training will be running next year, and we'll be running approximately 3 to 4 sessions in the community for that. So we're really excited to bring to you an even more detailed version of this presentation to really build up your practical skills around making services successful. How are we going for time?
So good. You're setting the benchmark so high.
I'm trying not to talk too fast. So this is a little quote from, I did some consultation with our in-house group of women with disabilities, so they're called our experts by experience. And I asked them, what ideas or thoughts would you like the people that we train to leave with and take into their work? And one of their answers was to be excited. Being excited about working with a whole population of women they've previously not worked with before. So I think that's a really positive way to think of this idea. Don't think of it as like an extra thing. It's not, it's not something that's meant to make your life harder or more difficult. It's being able to make your service have the greatest amount of impact that it can have in the community. So yeah, I think that's...
Oh, there's one more.
Oh, there's one more.
Thanks, Zoe. So lastly, we just wanted to say thank you for your time, and we've got some links to resources here, including some links to how to make disability action plans, and if you go to the Australian Human Rights Commission, you can see a log of disability action plans that have been developed, and in the next few years you'll start to see Victorian public hospitals disability action plans there, and we've got some guides on developing resources for women with disabilities here. They're around violence, but we'll give you a little bit of a framework for how you want to work. Thank you so much.
I'm sorry, Jen and Zoe, you've just set the benchmark so high with your beautiful timing. But also what I really appreciated about your presentation is giving us in the room lots of ideas about things that we could do better. Yeah, so thank you for that, and at so many different levels and in so many ways. I think you could have easily talked for double or triple the time and we'd have learned more, but are you going to be here for the day? Will we be able to talk to you some more?
And a member of Women with Disabilities Victoria, Nicole's going to be on the panel later, which will be great.
Oh, lovely.
Yes,
okay, thank you so much. Can we give them a big hand? Next we have Jasmine Chin. Fabulous Jasmine. I've had the great privilege of working with her. We had a nice gala last year, didn't we? That was fun. Jasmine is the Research, Advocacy and Policy Manager at MCWH. She has a PhD in Cultural Studies. I didn't even know this till I read your bio. And a Graduate Diploma of Education. She's so talented. I thought she was talented anyway, but now it's like more talented. And since joining MCWH in 2012, Jasmine's worked in a number of research administrative project and communication roles, including projects related to preventing violence against women, sexual and reproductive health, and intersectional approaches to migrant women's health. Can we welcome Jasmine warmly, please?
Thank you.
Do you need some water, darling?
I think it's okay.
You're okay.
I think I'm okay.
Just give me a sign.
I'm feeling really under pressure because of that time, you know, setting the bar. I know that this presentation is a bit too long, so I'm going to talk really fast. Apologies in advance, but anyway, bear with me. I'm really excited to be here, so thanks so much to Women's Health Vic for having me. Do I have a clicker? I do. No, wrong way. So I'd also like to acknowledge the traditional owners of the land that we're on today, the Wurundjeri people of the Kulin Nation, and I want to pay my respects to their elders, past, present and emerging, and to recognise that sovereignty has never been ceded. Pay my respects to Aboriginal people who are in the room today, and also just because it's sexual and reproductive health that we're all here for, I want to acknowledge the generations of Jabberung women who gave birth under the sacred trees near Ararat, and express my solidarity and my admiration for the Jabberung Embassy and everything that they're doing to protect that land and its legacy. As Multicultural MCWH, we look to Aboriginal women for their leadership and their strength in advocating for the rights of their communities for health and wellbeing and safety. So I work at the Multicultural Centre for Women's Health, which has been running health education programs for women since 1978. And we're a health organisation that's run by and for migrant women, and we're really very proud of our history and the work that we do. So way back when, we began as a project called Action for Family Planning, which went to factories around Melbourne to deliver education about contraception and family planning and reproductive health to all the migrant women who worked there, and we did it in their first language, and it made a huge impact. So at that time, there was a really clear recognition of the need for work like ours, because many migrant women couldn't access information in their own language. They also couldn't get to the GPs outside of their really long factory work hours. And when they got there, they weren't really able to kind of have the kind of conversations that they wanted to with their GPs. And so today we continue to do the same health education for women, delivered by other women who share language, culture and an experience of migration and settlement in Australia. And our health education is a statewide service that's funded by the Victorian government. And we have sort of a casual staff of about 20 bilingual health educators, one who Mumtaz is speaking later today, which will be brilliant. And they deliver health education in about 22 languages. And we love opportunities like this to talk about our work, because many of the issues that women faced in 1978 unfortunately haven't changed, and you probably all know this, that it's the same old story, unfortunately. But not only have the problems not changed, they've become more pressing. So at the last census in 2016, there were 3 million women living in Victoria, of whom 1 million was born overseas, and a total of about 29% were born in a mainly non-English speaking country. So in the last 10 years, the number of women who come from a non-mainly English speaking country has doubled. And from our perspective, well, MCWH's funding hasn't, which I think is indicative of the real sort of growing need for focusing on migrant women's sexual and reproductive health. And the immigration landscape has also, I think, become more complex. So there's a huge number of international students who are studying and living in Victoria now. They don't always have access to the same sorts of the services that for sexual and reproductive health and pregnancy-related health. There's also asylum seekers. There's about 300 people in detention in Victoria. Migrant and refugee families are moving to regional and rural areas, and then there's partner visas and work visas and all kinds of visas that make the landscape really complicated for women who are living in Victoria, but also for all of us as service providers, knowing what their eligibility is. So I just wanted to say that Women with Disabilities Victoria, thank you, that presentation was amazing. I took heaps of notes as well. And everybody's health is really important, and there are so many different groups that have health disparities that can be addressed through increasing access and equity. And a lot of the kind of amazing points that women with disabilities made kind of would also, by doing that kind of work, you also increase access and equity for everyone. So I'm covering a lot of ground, and there's lots of synergies with what you said, and you probably said it better, but we'll just keep going anyway, I've written it. So there are some significant gaps, and there are some greater risks for migrant women that I just want to cover, just to, highlight for you. And again, similarly to women with disabilities, one of the most significant gaps is data. So current knowledge about the sexual and reproductive health of migrant and refugee women is really difficult to come by. Disaggregating data is often really difficult, but also the way that we collect data around that, whether we're collecting for language, whether we're collecting for country of birth, whether that actually reflects somebody's experience if they lived in a refugee camp in a country that wasn't where they were born. All of these things kind of make it really difficult to accurately say and plan about how to, based on evidence, make migrant and refugee women's sexual and reproductive health better. However, current state and national data does suggest that migrant and refugee women are at greater risk of suffering poorer maternal and child health outcomes. So, for example, we know that they're less likely than Australian-born non-Indigenous women to have adequate information and familiarity with modern contraceptive methods. We know that they're more likely to have a caesarean or instrument-assisted delivery, more likely to have adverse perinatal outcomes, and at greater risk of contracting a sexually transmitted condition such as HIV or hepatitis B. And despite those greater risks, we also know from the current evidence that migrant women are less likely to use mainstream health services and seek support. And a good example of this is stillbirths. In terms of the importance of looking outside the practices in the clinic and bringing women in, 1/3 of stillbirths, according to current research in Australia, are born to migrant women, which is quite high. It's again not as high as for Aboriginal women, but it's a significant statistic. And research also indicates a link between high stillbirth risk and late access to antenatal care, which we know that migrant women come in later to antenatal care, and there are lots of contributing reasons why, but we don't know 100%. So, and I also think it's worth mentioning here as well that once women do access services, I think it has to be said that racism is a sexual and reproductive health issue as well. And VACCHO has done some amazing research on how much racism impacts women's health and well-being. But one of the statistics I always find really compelling is that a study done on maternal exposure to racism shows that it impacts on the fetus. So racism is something that affects generations and lasts for a long, long time. So what can we do? At MCWH, as any of you know who have worked with us before, we take an intersectional approach, or we try to take an intersectional approach to our work. And that means lots of things, but for us it really boils down to looking at the intersecting forms of discrimination that are impacting on migrant women's health. So in this context today, I think thinking about access and equity for migrant women, I think one of the ways that we can take an intersectional approach is by challenging our assumptions about the barriers and challenging the assumption that culture is a barrier in and of itself. Because when you look at some of the main kind of frustrations for migrant women who are accessing services, they're not really cultural so much in terms of the community that's involved, but they're structural. So they're about social isolation and the lack of family support when you move here, unfamiliarity with the Australian health system, which I also, being Australian born, have no idea how to navigate, transportation issues and costs, visa entitlements, lack of access to health information, and poverty and financial hardship. All of those things really play into what makes it difficult for migrant women to access services, but they're not necessarily something that is about their culture. And I think it's important to kind of think outside that box. So I guess a cross-cultural and intersectional approach is really about shifting from learning the idea that we have to learn about other cultures to reflecting on our own workplace culture and what are the processes that we take for granted that are actually excluding people or limiting their access. And it's also about, exactly as Jen and Zoe were saying, thinking about where there are gaps and where you can see structural gaps, advocating for structural change. So again, with length of time for clients who are going to use interpreters, knowing that that's an issue, instead of kind of just having it sit there as this stress that, you know, impacts on your day-to-day when you know that things are going over time, maybe looking at ways to build in longer clinic time. A cross-cultural and intersectional approach also means asking migrant women about what they need. So it's about working with them as equal partners in their own health, and that can mean bringing a diverse range of faces into your workplace, because it does really make a difference if women can see that the workplace is representing them and reflecting their experience. And also just involving them in processes, consultation, asking women what they want, which sounds very basic, but this is the video, but I'm not going to have time to show it. But I suppose, speaking of working with women, we really are big believers at SRH in bilingual health education. It's really not just about speaking another language, which you can do through interpreters, but it's about understanding where women are coming from and what kind of experiences they've gone through, which sometimes if you haven't lived through it, you really just can't see those barriers. So it really helps to value lived experience, which the panel is doing in the afternoon, which I think is brilliant. Key messages. So work with migrant women as equal partners in their own health. Think about the way that you do things and who benefits from that or doesn't benefit from it as a result. And think outside the clinic. You know, who are you not seeing? Or think outside the service. Who is it that's missing out? And maybe just to, you know, we often talk about, oh, people are hard to reach, but think about reaching out instead, because it's meant to be a relationship. You can't just sort of sit there and wait for them to not come. I just wanted to plug that we have a multilingual catalogue on our website which has women's health information in over 70 languages. So in terms of reaching out, we really welcome you to access the catalogue and download things for free, or you can call us and we'll send you things for free. And also I wanted to invite you all to a Migrant Women's Sexual and Reproductive Health Conference that we're putting on in February, and we'd love you to be there. We'd love to hear you give papers and join in the conversation. And I think that's my time.
It's your time.
Thanks so much for bearing with me.
Thank you, Jasmine. That was awesome. I think one of the themes that's starting to come through in the presentations we've had so far is just the absence of data that can be used in ways that can make a difference. And I think we're going to start seeing some really interesting themes through the day, and you brought those out really beautifully, Jasmine. I was thinking about the access. The other thing I wanted to do a plug for you on was the fabulous newsletter that Multicultural Women's Health have. If you don't already subscribe to it, I really rate it. Like, even before I'd met them, when I first came to Australia, I sent them an email and I said, I love your newsletter so much, because there's just something for everybody. I really appreciate how our first group of speakers have also said there are tons of resources there, right? And I think also, Jasmine, what you covered so beautifully was there are so many ways that we can do things. We don't have to be overwhelmed, you know, but the other question that I have really is, you know, presence doesn't always equal power. So, you know, that's a question that I want us all to be thinking about today. Just because you're in the room doesn't mean you've got a say in the room, yeah? So I'm looking forward to this afternoon as well. Is there a way people can see that video? They can just go to the website, eh? So our next speaker is Amelia Arnold. Where's Amelia? Amelia works as a trainer, facilitator, researcher and consultant. That's a lot of things. In areas involving mental health, fertility and LGBTIQA+ topics. You're the project lead for the Suicide Prevention Project, I'm going to start summarising now, Because I'll just use up all your time with the intro. And you're developing some resources on affirmative practice training to mainstream mental health first responders and primary health care workers in an effort to improve mental health crisis experiences. You have a double master's in reproductive medicine and women's health medicine, and you've worked with the Fertility Preservation Task Force, Melbourne IVF and Queensland Fertility Group in donor coordination, research and patient support roles. Amelia is a bisexual cisgender woman. Then we have Julian. We've met before, Julian? Dr. Julian Grace is the lead trainer for the Transgender and Gender Diverse Healthcare Training Project at Thorne Harbour Health. They coordinate an evidence-based statewide training program with the goal of improving transgender, gender diverse and non-binary community sensitivity and building mainstream healthcare sector capacity to meet the health needs of transgender, gender diverse and non-binary Victorians. We are so lucky to have you both, aren't we? We are so lucky. They're also a qualified osteopath, currently practicing at the Equinox Health Clinic for trans and gender diverse communities. I'll just skip some of the other bit. Is that all right? Can we give them a warm welcome?
Thank you, Ruth, for introducing us, and for Women's Health Victoria for welcoming us along today. And the speakers that we've already heard from, it's already been mentioned that there'll be a lot of overlap, I think, with some of these presentations, in that it's not as scary as it seems to work with folks from minority groups, and really just delighted to be here. My name's Amelia, my pronouns are she and her, and I work within the Training and Capacity Building Department at Thorne Harbour Health, and I'm joined by my colleague Julian. Their pronouns are they and them, and they work on the Trans and Gender Diverse Affirmative Practice Training Project. We're here today to bring the LGBTIQA+ lens to sexual and reproductive health. That's a really big topic, and we've only got 15 minutes, and we're going to be, I think, smacked on the bum if we go a little bit longer than we should. Yeah, I thought so. So, in a nutshell, we work in a medical system and have also been educated within systems that are largely heteronormative, gendered for the large part, especially healthcare, and this is also cisgender centric. For example, by virtue of the fact that a lot of services that people who have been assigned female at birth and assigned male at birth are often referred to as women's and men's services in a trans exclusionary way. We are also educated and trained under a white colonialist-centric lens, which is also ableist and pathologises differences. So I'd like to take this point to pause and also acknowledge that we are meeting on the lands of the Kulin Nations, and pay my respects to elders past, present, emerging, and any Aboriginal folks who are here today on unceded land where sovereignty was never ceded. So all of these things present challenges for working with a whole host of different people. Some of those people may be LGBTIQ+, maybe people of colour, First Nations people, people who live with disability and or neurodiversity, and all together. People don't just necessarily belong to just one of these groups. For the largest part, most people will have multiple minority identities as well, and that's something that we should keep in mind. And largely when we're talking about healthcare, a lot of that work is unlearning those assumptions and things that we have been taught about how people are, and that we can't make assumptions about what kind of service people will need just from looking at them. So, relating to sexual and reproductive health services for people from sexuality, gender and sex diverse groups, for the largest part also we will hear the acronym LGBTIQ+, sometimes LGBTIQA+, and but the community is homogenised into one kind of group, but we're actually a lot of different groups that have different needs and different lived experiences. So in terms of sexuality diverse communities, we're referring to lesbian communities, gay communities, bisexual and multi-gender attracted people, and also queer people. So queer can often be used as an umbrella term, or also a way to describe any sexuality, gender or sex difference. We also are represented with gender diverse communities, so for example people who belong to transgender experience, and also people who identify as non-binary, as gender diverse, genderqueer or agender, without gender. Also sex diverse communities, so people living with intersex variations, which people often forget about. When we're talking about lesbian, bisexual and queer women's sexual and reproductive health, there are some difficulty in terms of representing what we mean and who we're talking about in these spaces. So LGBTIQ plus people may be engaging in sex with people of all gender identities with varied bodies and in varied practice. While trans women's health should absolutely be considered under the umbrella of women's health, we recognise that much of the data that captures women's health is not including trans experience within those statistics, and that many current women's health studies do not include trans women and include data from trans and gender diverse people who were assigned female at birth and who do not identify as women. Inappropriate demographic data collection, so for example restricting gender options when working with people, conflation of sex, anatomy and gender, and trans and gender diverse fear of disclosure all contribute to the fact that we don't have awesome data or any data about this. So what we do know, so SWASH is the Sydney Women and Sexual Health Survey, which has been collecting data for 20 years out of ACON, which is in New South Wales. It's a fantastic resource. We've provided a link at the end of the, somewhere that you can go on the internet to look that up. You can't really click the link from where you are. But it's a fantastic resource that's got decades of information about LBQ women. So lesbian, bisexual and queer women and people assigned female at birth, so the acronym AFAB, folks are less likely to have completed HPV vaccinations and STI checks, which came out of the 2016 SWASH report. The concern here is that these groups may not benefit from the reduced incidence of genital warts, nor, more importantly, protection from HPV-related cervical cancer, and also may not be getting screened. Women who had ever had sex with a cis man were significantly more likely to have had STI tests at 72% compared to women who had never had sex with a cis man, which was 45%, so that's significantly lower. LGBTIQ plus people in general may not respond to health promotion campaigns that are directed at an assumed heterosexual audience as well. They'll look at this and say, oh, it's not for me, it's not relevant, hence the decreased likelihood in having screens themselves. And in 2016, SWASH also asked respondents where they obtained their sexual health information, and the most commonly reported sources were online and through their GPs, so these are the areas in which we need to work. The fact that, relating to lesbians specifically, the fact that lesbians have a sexual history that includes men, and then that gay men also have a sexual history that includes women, is perhaps, we're familiar with that within community, but mainstream service providers are often quite shocked when they hear that. So put that in. Relating to gay and bisexual and queer men's health and sexual and reproductive health, pre-exposure prophylaxis, PrEP, is now the most commonly used HIV risk reduction strategy with casual partners in Melbourne through our sampling data. Since PrEP was added to the PBS, PrEP usage has increased, and the most popular way to obtain it is through a chemist, which is super simple and easy. Also, rates of HIV and STI testing have also risen a lot in relation to that. However, the proportion of men with regular partners having anal sex without a condom has increased to 70% and 60% when using casual partners, and that's likely related to the fact that U equals U, undetectable equals untransmissible. So 97% of men who are HIV positive are accessing treatment, and 95% of this group report having undetectable HIV viral load. So the current evidence base, as well as all of these folks who I won't necessarily read out to you for time, back the statement that an undetectable viral load equals an untransmissible viral load. We'll just quickly touch on intersex communities. So intersex folks, people who are born with intersex variations, are born with physical sex characteristics that don't fit within medical norms for female or male bodies. Some intersex people may have had surgery as an infant, which we have all sorts of opinions about. Intersex people have many different kinds of bodies and life experiences, and we'd really encourage you to engage directly with intersex community to provide their lived experience and their training, which is incredible. We've had it done within our own organisations. We We don't necessarily have that lived experience within our training team, so we don't talk to it too much, but I would really encourage you to make contact with the Intersex Human Rights Australia, and Julian will talk more about some upcoming events that they have coming up for Intersex Awareness Day, and I'd like to pass over to them.
So, as you know, I'm Julian. This is going to be echoing a lot of what other people have said. So we don't have accurate data on trans and gender diverse communities for a number of reasons. It's safe to say that there are more trans and non-binary people in this room than a lot of people might realise. Same as in the studies that we looked at before, like the SWASH study, the gay men's study, there's going to be trans and gender diverse people within those populations. So it's important to remember there's no single way to be trans. Don't expect every trans patient or client to want to medically transition at all. That's perfectly valid as well. And some trans people also identify as straight, so wouldn't necessarily feel comfortable being under the LGBTI umbrella. So there's a lot going on here. We've had incredible advances in TGD healthcare recently, but we're actually still really behind. There are some really big questions that we need answering, and they're very important questions that need immediate funding to have research done on. So there's a group called Trans Medical Research out of the Austin that are doing some fantastic work. What we do know in terms of sexual and reproductive health, many trans people do want to have a family, and the information that we get when we, or if we choose to medically transition, is limited and quite sporadic. We don't completely know how this affects fertility and what our options are, and to be honest, often, especially if you have OVA, it's ridiculously expensive. Yeah? So neither testosterone nor estrogen therapy equal contraception, and conception is possible when someone with a uterus is amenorrheic. Whether it's probable or not is another thing and another study. So, trans men can be pregnant. I'm just going to put that out there. I know it blows a lot of people's minds, but it's really important to remember. Okay, this is a quick slide from a really amazing study that actually just came out this year from Sydney on trans and gender diverse sexual health. It had, I think, the biggest number of participants in a trans study yet in Australia. What's nice to see is that community health and sexual health are actually being described in terms of access more positively than a lot of other services. So that's good, but we still have a long way to go. Yeah? So affirmative practice, I'm assuming people have heard of that phrase in regards to many different demographics. Without going through that whole list, you kind of have a three-tier system. So tolerant practice is the classic old, oh, I treat everyone the same. Inclusive practice, maybe they put a rainbow sticker in the front window. Yeah? So that's where you're inviting people in, like you were saying before, you're inviting people in, but they're not actually doing the work behind that to make it a safe and appropriate environment. So affirmative practice means actually doing the legwork, not just inviting people in, but making sure they're represented in your staff, in your flyers, yada yada. So, I'm going to say it anyway. Pronouns. I'm not going to go into it heaps because I've noticed a lot of people actually have pronoun badges on today, which is fantastic. I noticed some little lanyard buttons and things. But you might notice that Amelia and I have both written our pronouns on our name tag, and maybe having a space on the name tag is a good place to start. There's some more information if you need it. So misgendering is a term used to describe the use of incorrect pronouns or other gender descriptors, and it can be completely accidental or it can be deliberate. Obviously that's worse. If you misgender someone, the best approach is a quick apology, and that's it. You know, don't labour it, it gets really awkward. And if you notice that one of your colleagues is either accidentally or intentionally misgendering someone, pull them up on it. This is part of affirmative practice, is that we as trans people, as allies, more importantly, need to be stepping up. Yeah? So, what I do, a quick plug. So I'm part of this consortium that's Thorne Harbour Health, Your Community Health, and Ballarat Community Health, and the Austin Hospital. We're coordinating a statewide evidence-based training program for any health professionals, particularly aimed at GPs, but really trying to get out there, especially, we saw from that infographic before, hospitals in general really need to lift their game. So it's designed and delivered by trans and gender diverse health professionals. It's myself, there's Gaby in the back of the room as well, who's fantastic. Also works at Equinox, which you heard about before. So why it's important, there is a huge statistical disparity between TGD, trans and gender diverse health outcomes, compared with the general population, and this isn't just in terms of sexual and reproductive health. With, looking at suicide rates, rates of domestic violence, it's quite terrible. Safe and accessible healthcare is a key factor in rectifying all of this. We're all here because we know how important healthcare is. So if you'd like to receive training, if you'd like to get in touch, you can take a photo of this, but we also have some more information later very quickly. So here are some key studies that we've referenced. I'd highly recommend taking a quick photo of that. They're all quite recent and very impressive.
Julian, are you going to share your slides as well?
Oh yeah, we can. Yeah, why not?
That could be another.
That's, again, a little plug if you want to get your organisation or your workplace a bit more up to speed on this, because this is just a tiny taster of what we need to know, and hopefully it can be a bit of a call to action as well, so that we can all do better. Thank you.
Yay. Thank you so much. More speakers that I could just listen to all day. I think we're seeing some themes here, aren't we, about at what level do we make spaces inclusive? So there's that very symbolic kind of, having the rainbow, or, having flags, having sort of things that people can see, and then how do we ensure that structurally we're enabling people to get the kind of health care that's appropriate and effective? And I think this is, in a way, the last bastion, really, because we live in such a heteronormative world. It's overwhelmingly so, yeah? So we're talking about how do we change this conditioning that's so unrelenting all around us. So thank you very much for that. Our final speaker before we have a Q&A, our next speaker is Gaby Bruning. Gaby, sorry. Gaby Bruning is the statewide AOD and mental health coordinator at VACCHO. Gaby also works for North Richmond Community Health in the medically supervised injecting room as a harm reduction practitioner. Gaby's background is working in the alcohol and other drug sector with Aboriginal people, supporting them with their levels of dependency and advocating with the mental health system. Gaby, I think you've come a long way as well this morning, haven't you? You've been travelling to get here.
Yes.
So we're very happy to have you. Welcome.
Thank you. I did get here late, so I apologise that I missed all the other presentations. But I do want to start off by acknowledging that we are on contested land, and we are on the land of the Kulin Nations, the Wurundjeri people and the Bunurong people. I also want to pay respect to elders past, present and emerging. I also want to acknowledge that these are not my slides. Anne, who I work with, she's the Sexual Health and BBV coordinator at VACCHO, and she asked me to step in for hers. Yeah, these are not mine. And I also brought no notes, so I'm reading off my phone. So that's our building. We're based in Collingwood. So we are the Victorian Aboriginal Community Controlled Health Organisation, which is made up of different members across the state, so it's the different ACCOs. I don't know if anyone's ever been to an ACCO before. We've got some based in Melbourne, also around the state. Anne likes to include this slide and everything because it's like we're all sort of riding the wave and sort of trying to navigate through that big storm. So Aboriginal Health Services are dealing with many chronic and complex health conditions. Trauma-informed practice is essential. ACCOs play a great role in wraparound services. So there's a lot of chronic health conditions. The social determinants of health is a big factor, and the effects of colonisation, which is ongoing, and I don't think we're going to find a solution anytime soon. And then, unfortunately though, with within the ACCOs, sexual and reproductive health may not always be priority. It's sort of more around families and those chronic health conditions and drug and alcohol. So key issues for mainstream women's services. We will share the slides if anyone wants to watch the links afterwards.
$100.
Yeah, totally. Support community.
Yeah. Pay the rent.
So, yeah, it's really important that, you know, not only just creating a safe space for women, but creating a culturally safe space for Aboriginal and Torres Strait Islander people. Understanding and acknowledging the importance of women's business, that it is different. So you've got men's and women's business, and you know that a female may not be comfortable in many settings, but they may not feel comfortable seeing a man when it comes to women's business. And that there's choice, and that sometimes women don't want to actually access a community-controlled health service. You know, community is very small. We do talk, unfortunately. There is Superior Grapevine. And it's also convenient. Sometimes there's no health service close by, or they just choose not to access one. So asking the question, do you actually ask the question, do you identify as Aboriginal or Torres Strait Islander? Is that something you do with your general practice? It's also important to understand why we actually ask the question, because it's not just about data and collecting those stats to say that yes, we are servicing this cohort of people. It's about making sure that if you are asking the question, that you can identify that there are specialised services that they can access. It's about respect as well. It's also acknowledging that, you know, that we have also endured a lot through history and continue to endure a lot, and there's a lot of lack of understanding around culture. So it's just acknowledging and respect. And understanding that culture is protective and safe. And it helps help the design and delivery and evaluation of services to be more responsive. So as I was saying, that there might be more tailored services for Aboriginal people. And recognition that sometimes mainstream services need to give Aboriginal people more control. More listening is needed and less assumptions. And as I said before, it's a wraparound service. And early intervention, identification of predisposing illness, and monitor health patterns. Aboriginal women are under-screened in bowel, breast and cervical screening. Conversations with community revealed that many women felt uncomfortable and unsafe. So VACCHO, we've actually started a new initiative. So there's a modesty shawl, which I'll get to. And they've worked with the different health services around the state to help create this. So this is the first one that was created, so it can be used for breast screening, but also like if someone needs to have pap smears and those kind of things. So there is a story attached to it. It says, our journeys are many, but our travelling path leads us back to Mother Earth, connecting us to her spiritual being. Stand barefoot on our ancestral homelands. Lay down beneath the sacred birthing tree that stands tall with deep roots into Mother Earth. Listen to the song lines, welcome in a new dawn and new beginnings. And this is from Lynette Briggs, who's a Wiradjuri and Yorta Yorta woman. So this is essentially how it's used. So it's something, it's nice to feel that you are culturally supported, and it's just, yeah. So this is Lynette Briggs. So Susan, who's on the left, she's the one that helped implement this, and so they're actually working with other ACCOs around the state. So there was one up in Shepparton, and then, so these are the different ACCOs that are going to be a part of it. So Dorrity in Portland, Windamara in Hayward, Gunditjmara in Warrnambool, Karay Health, Watherong in Geelong, Rumballara in Shep, and Rumiak in Sale. So which also then goes in with the breast screen bus. So they were there There is notes here. The first bus arrived in Portland for 5 days last week. A magnet of the artwork is put on the van too, and so that's Rose Hollis. So she's a community worker at Dorrity in Portland, and a total legend apparently. That's what Anne thinks. I've never met her. Rose had her breast screen in the morning and then spent the rest of the day driving around Portland, picking up community members and driving them with the mobile screening service. So it's also local artists that help design these, which is really cool. And that's one of the health workers, Amelia from Portland. So how do you actually engage with Aboriginal communities? Like, what's actually working well for you guys? It's something to actually reflect on, because we may think that we're doing a good job, but if you take the time and actually stop and speak with community, maybe there's things that could be changed. How are you sure that your practice is culturally safe? Are you actually accessing cultural safety training? Do you have a reconciliation action plan? Is there an ongoing commitment? And are there any barriers? What are the barriers? Have you actually overcome any? And the referral pathways. Sometimes we make it a lot more difficult than what it should be when we refer out, but it should be simple, but it's also within community. We need to be mindful that, as I said, community is small and we all do know someone, we're all connected somehow. So ACCOs are under-resourced and under demand. They don't pay well. And people just, we work really hard, and yeah, it is hard work. And workforce turnover and lack of choice for gender, women's business and men's business. Building a skilled sexual and reproductive health workforce, understanding prevention, transmission, treatment, and generic services may not understand how ACCOs work. So this is what Anne essentially does. So she does statewide advocacy, sexual health and BBV, support system change, a lot is data-driven, sexual health and BBV training for ACCOs, and resource development. So this is one of our posters that get put out everywhere. She wanted to add the condom man. And yeah, so just some different things. But we will send out the slides if anyone's interested in actually getting them. We're all riding the wave yet again. Any questions? Are we doing questions?
We're doing questions.
We're doing questions afterwards. We're not doing questions. I apologise.
We've got a process.
So if anyone wants to contact Anne, this is how you can get her. So that's it. Thanks.
Thanks so much, Gaby. And I think what you've managed to do in a very short time is really kind of illustrate a lot of the kind of pressures and forces on the sector in terms of workforce development, but also trying to find ways to be responsive in quite challenging circumstances. So thank you for also stepping in and doing that so well. What we're going to do now, we're going to have quite a sort of facilitated process for our questions, and we're trying out the system of peer-reviewed questions because, you know, we're interested in rigour. So what we want to do is have 5 minutes for discussion where you get to speak with people on your table, but maybe also just take a minute to reflect on whether you've got some learning that's happened as a result of these presentations. And if you have a question, maybe sort of run it by people at your table. And what we're trying to do here is kind of try and get really fabulous questions for a short period of time. Because there are questions that are not questions. Sometimes they're comments, or sometimes they're, I'm feeling agitated and I don't know why I'm feeling agitated, or whatever. So what we want you to do is just take a few minutes to talk to each other about anything that's on your mind or a question you might be trying to frame. And then what we're going to do is ask you to think about two things. Is this a question or a statement? Is this question appropriate for the presenters and for the purposes of this forum? And what I'm going to do is invite panellists who've been speaking to come up and have a seat in your own time. So just 5 minutes for a quick chat.
Yeah, looks really tasty.
Okay, folks. We might get cracking. Lunch is actually in 5 minutes, but we thought we could eat into lunchtime by 5 minutes. So I had this cunning idea that we could generate the questions, because a famous philosopher once said the questions are as important as the answers. So I thought we could find out what all the questions are, and then whoever feels like answering a question on the panel can answer whatever they feel like answering, and if anything's left over, there's lunchtime. And if anyone doesn't want to answer a question at lunchtime, they can run for the hills, right? Is that a good idea? You know, just introducing a bit of fun into it. Okay.
Oh, you're all scared now. Oh, we've got one here. And what I might ask you to do is just introduce yourself and say what the question is.
Hi, my name is Asvini Subasinger. I'm a research fellow working with Daniel Maxwell on SPHERE at Monash University. And thank you so much, first of all, for your lovely presentations. And I think we were quite curious to find out whether access to medical abortion and long-acting reversible contraceptives are an issue in the minority groups that you've been discussing, and what we can do to improve access to these vital services.
So what I'm going to do is I'm going to collect the questions and see what other questions we have, just so we can make sure that no one misses out. Is that okay with you? Yeah. Anyone else got a question? And I'm walking to the back of the room. Okay, we've got one question. Excellent. How good is that? Oh, two.
Hi, I'm Shannon from Women's Health Grampians in Health Promotion for Sexual and Reproductive Health. If there was one thing that you absolutely want us to do and take away today, one thing, whether it's a piece of data or an action, what's the one thing that you want us to do?
I love that question. That's fabulous. Anyone else? Oh, here we go.
Hello, I'm Judy Walsh from Family Planning Victoria, and I'm interested in sex ed for kids in primary and secondary schools and making it reflect the experiences of all the children in the room. And I love your advice about that, because it's hard enough to get good sex ed happening in a classroom setting.
Lots of very interesting questions. Anyone else before I move to the front? Okay. Who wants to go first?
Alright.
Hey, go Gaby.
So I am a mother of a primary school age child and also one in year 7. And I think for me, more needs to be done, not just around like the very basics of what sex is and all the things that come with it, but it's you know, talking about porn, talking about enjoyment, talking about orgasms and masturbation and all of that kind of stuff. It needs to be inclusive of everything, but I think people are probably a bit more scared to touch on those topics because, you know, you don't want to traumatize these young minds and whatnot. But I think, you know, I grew up in an age where it was all shame. And I'm sure that everyone else did as well, and previous generations as well. So I think we need to have those honest and open conversations with our kids, and know that it's okay. We're not going to send them into having sex with everyone. They're not going to be hiding in the bathroom or bedroom and masturbating every day. But you know, just so they know. I mean, they might. That's okay. Exactly, it's totally fine. But you know, we're not going to be like, all right, that's what they're they're going to go do now because we've taught them what it is. But it's just, you know, we all experience this, so these are our little people, these are our future generations, so we need to actually educate them and teach them that there is no shame attached to this and that it's okay. So thank you.
Thank you. Who's going next? Oh, let's pass it along. We've got... Yeah, I'll give you that.
I'll keep on talking on that topic.
Excellent.
While we're on the same topic instead of jumping around. I take your points, and I think they're really important in talking about pleasure and consent and all of those things that are part of sex with other people that for the largest part are minimised for fear of hypersexualising children. And with also the assumption being that information about sex and pleasure and sexuality also will lead to specific things that people are fearful of, like, you know, masturbating every day. I think that's a great thing. That's just me personally. But it's also presenting different ways in which people have sex, and, you know, having sex with people of a variety of genders, of gender experiences, and that not presenting sexual education in a way that is largely cis and heteronormative, in that losing of virginity, in, you know, being penetration focused, all of those kinds of things I think is super important, and I'm sure work that you're already doing, but just keeping in mind when we're talking to young people, because like for myself, I didn't necessarily see sex with people other than cis men as an option for myself because it was not presented at school. So I was like, oh.
Can I, to add to that, is that okay?
I have the experience of coming from doing sex ed in schools with young people and now working in disability. So I think speaking to the disability part is kind of talking about that diversity. Like, there's a lot of the way that problems with sex are talked about is kind of in a medical way, like a lot of talk around dysfunction, whereas people aren't presented with the reality of people having different bodies that function in different ways, and especially in terms of, you know, equity and justice, like they're having the separation in the school system for children with disabilities into special schools. They essentially don't receive sex education, definitely not on the same basis as their non-disabled peers, and that's something that I think in your community, if you have a school like that, if you want to partner with them around doing some education, that's great. Please do that, because that's a really huge deficit that exists. And then what was my point? Oh, I love that there's people doing work in schools, and I think doing work in schools is really important, but I think it's also important to acknowledge that as a population there's poor sex education, and so having a really community-based approach is very important, because there's only so much that we can teach young people, and there's only so much time that we have with them, and you have to acknowledge that all the people in the community shape people's attitudes towards sex. So it's not just the parents, it's not just teachers, it's everyone, it's the way that everyone talks about it. So, you know, having programs that target young people is great, but acknowledging that you also have to look at everyone else who's in that community and, you know, shaping their attitudes.
So they have a context, right?
Yeah.
I'm wondering if we can leave your very specific question for lunchtime and people come to you if they've got a response to that. But just given that we've got 1 minute, could we perhaps have the one thing? I hate being reductionist because we've been talking about multiplicity and diversity and more. So I'm just wondering whether, I know that a lot of you have already given us some take-home messages, but I'm just wondering in an iterative sense, if from hearing each other or the conversation we've been having this morning, whether you've got something else to add.
I can do something really fast, agenda it for a staff meeting.
Yeah!
Yes. Sorry. You might have one, I don't know, but I'd say one point that probably hits a few subjects is the affirmative practice point, and remembering that it's not just about inclusivity. You can't invite people to the table but then not actually make space for them and not listen to them. Yeah? So this needs to be an active inclusion in affirmative practice, and I think that would help a lot of causes.
My take home for LGBTIQ plus folks is don't make assumptions on us by looking at us. You have no idea. Ask us questions.
So can I just say how to ask? How to ask, because I know there'll be people sitting here thinking,
questions.
Yeah.
Depends what you want to know. What are your pronouns? Well, these are my pronouns. What are your pronouns? Who are you having sex at the moment? Who are you having sex with? What type of sex are you having?
Which obviously you're not going to do in the cafeteria line. Like, some sort of, discretion.
Make it more fun.
Keep in mind the context in which you're asking the question and safety.
Yeah. Because one thing I'm aware of as we've been talking, and I'm breaking this I'm being a terrible MC at the moment, breaking my own rule. But I also think that this is something I want to throw into the whole room. How do we ask questions? Because we come, this has been a theme across everybody's presentations. How do we ask questions in a way that's not extractive?
I guess it would be sort of following on that theme, but what Gaby was saying about listening, and I guess it's about, asking questions can be really difficult. So maybe it's also about creating a space where people feel safe to talk and creating a space either by putting it on the staff agenda but bringing people to the table at the staff meetings that are representing different groups so that we actually have a voice in the decision making processes. But yes, what everybody said was great.
Once again, following on from that. Don't make assumptions. When you are working with Aboriginal people, don't assume that just because they don't look it, that they aren't. I know I don't look Aboriginal, but I am, and people make the assumption. And don't ask those really ignorant questions of, well, what percentage are you? Because it's actually really insulting, and it's not about what percentage we are, it's about the fact that we're holding on to our culture, and culture is what's really important. So just being mindful of the language that we're using, and like for everyone really, that what we say and how we ask it is really important.
Okay, folks, I don't like to keep anyone from food, especially myself. Can we please acknowledge this fabulous group of people who've shared their time, their energy, done a lot of preparation and thinking to give us their thoughts, but also there's something very personal about the kinds of experiences that many of you have talked about. And I also think there's another layer of vulnerability when we're talking about lived experience and navigating systems that were not designed for you. So I just want to acknowledge that with everybody here. And can we get a big clap? So back here at 1:30, have some food, have some fresh air.